Good evening, ladies and gentlemen. I welcome you to the afternoon session, second afternoon session, a very interesting subject on the insurance. And allow me, in guise of introduction, to have an original information on which is the field of health insurance, what are the challenges, and following that, we will reshuffle the agenda. Madam Antonaki has asked to take first the floor. Mr. Kikilias and Mr. Kyriopoulos and Mr. Veliotes will follow. So we welcome you all. Πώς είναι ο καιρός στο Λονδίνο? Πολύ καλό. Πολύ καλό. Πολύ καλός είναι η απάντηση, σωστή. So we start with the first presentation. Could we please have the first slide from the technical support and please follow suit. First slide, please. Excellent. So we will discuss about the challenge of health insurance and analyze what should be done, the challenges, the future, and what is the current financial status. In the first slide, you would see the evolution of health expenditure. These are the final data issued by the National Statistics Authority, and we see the first sector, which is the state, the second is the private sector, that is out of pocket, what the patients pay, and the third is the field of the challenge that we mentioned, that is health insurance. Due to the financial crisis and the problems in the field sector, there has been a great shrinkage of the public expenditure. And this shrinkage, due to the clawback and rebate, burdened excessively the pharma industry and the households. From the games theory, who is the greatest beneficiary? Who has the prisoner's dilemma? What should the prisoner do and how can he evolve within the challenges, the economic challenges we are faced with? Here you see, therefore, that the field of private insurance of 500 million euros increased to almost 800 million euros. Analyzing this fluctuation at the percent basis, we see that the public expenditure shrunk by half, sending a huge load to the private sector, where the private expenditure, this out-of-pocket paid by the households, paid this crisis. We'll see later with Mr. Kyriopoulos, Ilias Kyriopoulos' presence, the son that is, not the father. We will see how these households have paid dearly on catastrophic price this crisis. So who is the ultimate beneficiary and whom do we have here in this around this table? This table says that 47% increase in private insurance. So run to get privately insured because challenges lie ahead. And therefore, the first question, Mr. Veliotes and Madam Antonaki, to what extent is the private insurance sector ready to offer modern and challenging programs to cover this increase and also the reverse trend in the health sector? That's an important challenge. And from the viewpoint of the composition percentage, we see from 2009 to 2019, no other sector increased. Quite the contrary, they all shrunk, while in the private insurance sector, we have more than double increase. From 2.2, it reaches a 5% growth. So we see that we have a very important problem to discuss today. And focusing on those that were greatly damaged in the field of sector, our country is ideal, as you see, as well as the USA. no one has such a high expenditure as the Greek households do. So, and we speak of a national health system, in other words, but with the highest payment out of pocket, even more than the USA. And here lies the challenge and contradiction. How well does the public sector operate, and how much this load on the households is transformed? Is it transformed into private insurance contracts? Or does it have catastrophic expenditure, additional burden on the shoulder of Atlas of the Greek households? And reversely, we see from 2007, before the crisis, till 2020, did we have a reduction of the private expenditure? That is what households paid out of pocket. No, this is not the case. Quite the contrary, it was increased. And if you get to see this increase, we in economics, health economics, we are always marginal, dealing with dynamic analysis and marginal analysis and so forth. We see here, however, that the transfer was the biggest from all the other countries. And we have a public health system. Don't you dare doubt that. And if we see what private expenditure has managed to do, and Mr. Ilias Kyriopoulos will discuss that from London with the excellent studies elaborated there with Mr. Moskialos and his group there, and I'll humbly mention our team as well from the University of Athens, you see that there's a very, very positive, strong correlation between the out-of-the-pocket expenditure and the distraction it goes through. And this distractive expenditure is not private. Let us make a distinction. The distractive expenditure is the one that the household refuses to buy milk, refuses and abdicates the main needs, the proper nutrition, in order to buy health services. Therefore, we see that there is a positive correlation between catastrophic expenditure and private health expenditure. And we see here that our country has a very high rank vis-à-vis Latvia, Ukraine, and so forth on this curve. Here are two indicative references, reports made, one with Mr. Hadzaras at Social Science and Medicine, The Voice of Life, and Mr. Ilias Kyriopoulos, along with Mr. Ilias Moskialos from London, two important studies that have reports that have studied in depth the impact of distractive expenditure. And let us see the catastrophic scenario in our country. Where are we? Greece, here we see the increase of GDP on a quarterly basis, and you see from 1996 until 2021 that we have the data. Before the crisis, Greece was the ideal country. Olympic Games, sea, sun, tourism, you name it. The best one could imagine. Double growth rates in relation to the other EU countries. And there comes the crisis. It is the longest. No other country has had a 10-year crisis cycle. It was with a deeper recession, where within 2011, 2013, from the roof of the economy where we enjoyed the excellent view of scenery, we were in the basement, under the basement actually. And then after the COVID period, we see whereby comparing the second stage of COVID after the 10-year crisis, we see that in the first semester, 2020, the reduction of the GDP was 17%. 2011 and 2012, 17.5% GDP shrinking during the first semester of 2020. So from one crisis to a deeper one. So where's the future? Things are optimistic. We should not make assumptions because the recent forecasts we see in the blue is Greece, and with yellow you see Portugal. You see Portugal, they managed to have a recovery, quicker recovery during the crisis. We lagged behind. In 2019, 2020, We had the first big recession, and you see from 2021 and onwards, crystal clear spring air. We reached a 2.53% of growth. And the major challenge today is the following. We have this whole recovery, Mr. Veliotes, Madam Antonaki, and the field of health insurance. How long will it take? Will it ride the wave so as to exploit this opening of the market? Are you ready? To what extent are you ready? And to what extent are you ready to make strategic alliances? And through this complex system of health, how ready are you to offer special programs to patients? How ready are you to negotiate with the government new, affordable, accessible, and challenging programs securing greater protection umbrella? And how ready are you, along with the pharma industry and the other stakeholders of the system, of the health system, employers, pharma companies, hospitals, and so forth? These stakeholders, that's the word that I was trying to translate into Greek, says the speaker. How ready are you to respond to those challenges? So we do introductory remarks. I warmly thank you. I think we opened the dialogue with a well-documented introduction. And I give the floor right away to Madam Antonaki. You have the floor.
Thank you very much. Following the very interesting and important introductory remarks, I would like to thank the organizing committee of the conference for inviting me in order to represent the Hellenic Association of Insurance Companies, and in order to talk about this very important topic of the reform of the public health system. First and foremost, I would like to say that the crisis and the COVID-19 pandemic tested the resilience of health systems around the world, and of course in Greece. Undoubtedly, it was one of the biggest challenges that the national health systems ever faced, and it showcased the pathogenicities, but also their strong points. One of the strong points of our own national health system was the human resources, the staff of the public hospitals, who, from the very first moment of the crisis of COVID-19, were at the center of the effort made to deal with the pandemic and to save lives. In this very difficult period, we all realized that the public system did whatever it could in order to meet the challenge. However, we should say that it is a system that didn't manage to radically change during the last 50 years. The weaknesses of our national system, be it in healthcare and in insurance, became evident during the healthcare crisis. And by weaknesses, I mean the weaknesses pertaining to the provision of health services, but also those who have to do with the funding of the health services. In order to become a little bit more specific, starting with the provision and organization of health services. I would like to talk about the hospital-centered system. Our system is centered on the hospitals, and I would also like to touch upon the inefficient organization of primary health care, hospital care, and long-term care. Now, with regard to the financing, what I mean by saying weakness, I mean that there is an unequal distribution of resources in our country. And as you said, there is also a very high participation of the households in this expenditure. You also talked about that. Now, let me elaborate on all this. The health system in our country, and this is my personal view, has been structured around the public hospitals. The public hospitals are many. They are mainly located in the big cities, especially in Attica. They have been designed following some specifications which do not meet the current demands, and they operate in an obsolete medical and technical equipment and with many shortages. Hospitalization is free, but of course there are long delays and waiting lines. We know that very well, and we all know that sometimes there are some illegal methods used in order to skip the line and being served first. Now, there are also the private clinics which support the public health system to the extent they can. These are located mainly in the capital. There are few. There is a monopoly in the sector of private clinics. They are far better equipped. And I would say they are among the best in Europe. It is very easy to be quickly served in these clinics, but of course, in order to be served, you need to pay a considerable amount of money. Even when the insured is using the public insurance scheme. How can a citizen be accepted and hospitalized in a private clinic? By using the programs of private insurance, which is called to cover the high hospitalization rates that the citizens cannot pay for. I would say that over 1.5 million citizens have already chosen to protect their life and their health by using private insurance policies. And this is the case when there is no tax incentive that would make this penetration, quote-unquote, of private insurance more accessible to the general population. So the private insurance is the one that helps citizens use the services of private centers and to pay either the total sum of hospitalization or the difference stemming from the coverage of the public health insurance and the rest. So if we take a look at the current insurance system, we would say that the way that the private insurance operates allows the shortening of the waiting time. Secondly, it saves money for public insurance because we all know that the EOPYY reimburses at a reduces rate the private centers compared to the public hospitals that they get all the money. Third, it creates a considerable amount of taxable products and services that create revenue for the state, because you know very well that all the products and services that are offered by the private insurance schemes are priced and taxed. It creates revenues from the turnovers of the insurance companies, and it also increases the turnover of the whole insurance cycle, since it makes easier the admission of a citizen in a private clinic. Now, what is the problem? The problem is that the role played by private insurance, which is actually a role of utmost importance, is not recognized officially by the state. In other words, private insurance is not treated as a truly important stakeholder of the health and insurance system of the country. So it is an unofficial role, but very meaningful one. And why am I saying meaningful? Because when more than 1.5 million citizens choose the private insurance, This proves that the public insurance system cannot meet their needs. And now I would like to talk about the pathogenicity that has to do with the financing of the system. We have said, and you have said, that based on data of 2019, out of 14 billion euros of health expenditure in the country, and despite the fact that we have institutionalized the universal public healthcare and insurance, 40% of this amount, that is 5.7 billion euros, is basically out-of-pocket money. Out of this amount, that is, out of the 5.7 billion euros, approximately 672 millions are paid by private insurance, whereas the remaining 5 billion are paid directly by the households, which, according to the available data, have spent 7.1% of their income on medical services. So let's focus on the numbers. 14 billion euros, 5.7 billion from the households, and only 0.7 from the private insurance. In addition, based on the OECD data, you also mentioned this, Mr. Yfantopoulos. So based on this data, it becomes evident that the public per capita expenditure in Greece in the years 2009 to 2019 receded by 14%, whereas in other countries there was an increase. It is a fact that the previous decade, that is the difficult decade of the financial crisis, had a very serious impact on the reduction of expenditure on health. And basically, it became an obstacle to any effort that could have been made in order to make the necessary restructure and reforms in the public health system. And as you said, immediately after the end of the financial crisis, there came the crisis of COVID-19 that took us back once again. So now there is a need to restart the economy. This is an imperative need. But in order for this to happen, what is needed are serious reforms, structural changes, in order to get a better and more robust economy and more effective social state. More than ever, what is absolutely necessary is to look at the future and take the necessary decisions that will improve the public health system. We believe that the sustainability of the public health system is linked with the private payments and other types of payments. These are the payments that ensure access, but at the same time promote inequalities and create devastating, catastrophic expenses for many households. This has to stop. So what do we think should be done? We think that the drug that is needed, the drug that will cure the system, is the use of private health insurance by a state. What do we mean by that? We mean the official recognition and institutionalization of the role played by private health insurance as a complementary aspect of the social insurance. In order for this to be done, we need to identify the amounts that can be covered by the main type of insurance and which by the complementary private insurance, because right now we are neither competitors nor complementary parties. I would say that we are moving in separate ways. In other words, we're talking about a new balance of management of health risks, and we are also talking about a rational mix of financing that will aim at the improvement of effectiveness. However, all of this should not happen randomly, but in order and based on plan. As a sector, what we want is no citizen being unable to meet their needs. What we want is to be able to be on the side of all citizens, along with social insurance, of course. We don't want to be on the side of those who have the luxury to pay. Private insurance, I believe, can indeed constitute an officially recognized party with a specific role in a new system of health. And with regard to us, we are absolutely willing to discuss with the state about how this can be done. In other words, we are willing to take part in a meaningful dialogue that will make private insurance a part of the solution to the existing problem. We cannot go on as usual. We cannot go on with and accept such increased burden placed on the shoulders of the Greek households. We need to find ways of more effective cooperation between the two systems. I'm sorry, Mr. Yfantopoulos, but I will not be able to follow the rest of the discussion. Thank you, Ms. Antonaki. We know that you need to be elsewhere. Thank you very much for taking part in this panel discussion and for sharing with us the view of the insurance side. I would like to keep note of two keywords, complementarity and recognition of the role of the private insurance. We will talk about these two later. Now I would like to give the floor directly. Thank you very much for being with us today. All the success to your work. Now I would like to give the floor to Mr. Kikilias, EOPYY.
Good afternoon. Welcome to our afternoon session. You have the floor. Thank you for the honorary invitation, and let me also convey the thanks of the governor of EOPYY, Madam Karpodini. With a great joy, EOPYY participates in the issue of health insurance as a basic parameter of the reform. The next slide, please. EOPYY was, of course, one of the biggest reform to date in the field of health. EOPYY has 105 points of service, either administrative or drugstores, where it distributes high-cost medicines at Hellenic sovereignty. Technical support. Could you please help, says the moderator? We have 1,500 employees of high caliber, specialists and scientific experts, who have 22,000 contracts. We participate all suppliers of health of all specialties participate and have contract with EOPYY. Clinics, hospitals, labs, physicians, and we cover 10 million people, practically the whole of the Greek population. And we manage 6 billion euros. Beyond the reform, however, EOPYY is also transformed and has set a strategic goal, starting timidly from 2012, from being a passive services buyer. Let us not forget that EOPYY is a buyer of health services based on historic data and drafting a very rudimentary budget. Over the last years, it has been transformed to a strategic purchaser where EOPYY plans, makes focus, and assesses the needs for the purchase of health services, so as to curtail expenditure by increase the services. Of course, an important role is played by the negotiation. It is institutionalized, and we have even WHO stated that in negotiating with the suppliers, we must set the volume on transparency and extrovert character, the quality, quantity, prices, and the way and the means of payment of the offered health services. Next slide, please. EOPYY, as you all know, collects from EFCA the contributions, social security contributions, and makes a distribution of that budget in order to cover all those needs that are being submitted by all the contracted health suppliers. And there lies a major issue. EOPYY perhaps should collect directly the income so as to be able to plan all health policies for the purchase of health services. And when discussing about beneficiaries, when we speak of the regulation, it's the indirectly insured persons, and we have the possibility for a European coverage with the European medical card, and a very important intervention is none other but the part of the non-insured persons, where through legal structures each citizen is covered by the services of EOPYY. Next slide, please. And as said by the World Health Organization, all people should have access to health services in order to be able to render the appropriate picture of the last period and even before the health crisis due to the pandemic. We've had the coverage of uninsured persons where they could and still can have access to ICU of the private sector. They have access of high-cost drugs, who have special arrangements for uninsured persons with renal failure that are covered by private clinics. If we bear in mind that many of such units in public hospitals did not have access because of the COVID, the EOPYY had greater reflexes, and it was founded with the appropriate dispositions. There was access, of course, of lab tests and many other technological products, and certain health services that cover social security. And all that, as we saw, in order to cover all these needs, it is important to increase our funding. Therefore, EOPYY, over the last years, as you would see in the evolution through time, in cooperation with the Ministry of Health, has managed to increase its annual revenues for health expenditure. In 2016, it was 1.4 billion euros, and currently we are at 1.500 billion euros. And similarly, in pharmaceutical care, we have reached 2.080 billion euros. And we don't stop here. We also seek for other funding. We have taken an extraordinary subsidy for COVID through a well-documented feasibility study. And we have also taken new funding through the NRSF, where we cover the expenditure of vaccines through special programs. And what does this entail in broadening the coverage of citizens, especially of sensitive social groups of the uninsured? You see that EOPYY covers 300 million people, 300 million, euros of expenditure. Therefore, we have some expenditure which is not eligible expenditure and has not been assessed in the before in the national budget, and still it is covered by us with this additional 300 million euros. A very important role, of course, very important issue for health services purchaser is to create those mechanisms, procedures, and tools for better agreements, such as an instrument is the establishment of negotiation committee. And through rules, transparency, quality, this institution tries to create the conditions that we will save financial resources and connects on very specific principles and rules the performance of the treatment with the payment and clinical efficiency. I can characteristically mention, well, here you can see within a time span of 8 months, the first results, encouraging results of the negotiation committee, where we had an excellent contract conducted for the radio drug FDG for the PET-CT test, which has been accepted by the BOD of EOPYY and has rendered more than 5.5 million euros on the annual basis. We also negotiated the multi-gene lab tests for breast cancer, which are very important because on the basis of the result, it is assessed whether a woman will have a breast surgery or not and opt solely for chemotherapy, having an additional benefit for EOPYY of 5 million euros. And if we introduce the other therapeutical schemes, there's a multiplying effect. And recently, because we are also involved in the services touching the margin of social care, which is various hostels of support settlements for supported stay. This was a very positive service acknowledged by the movement of persons with mobility problems, of impaired persons. We have special programs and negotiations in the field of diabetes and forms of cancer so as to attain equally interesting agreements. And needless to say that the main role of the organization is to establish benefits, the uniform rules for benefits. It's a framework that sets what EOPYY buys. An important factor is to lay the foundation of the principles the new regulation will be written. Therefore, the quality, transparency, and economic protection of sensitive groups is very important. We must also monitor the need of citizens and vulnerable patients groups so as to broaden the services rendered, to promote. Equally important is to promote innovation in technology, in health technology. And of course, as we had already in previous sessions, HTA must prevail so as to assess those technologies and buy that technology at the best possible price, most interesting price, if you like. And through this network of protection, or the umbrella, protection umbrella, we must save the public system from catastrophic, and households from catastrophic health expenditure. For us, a basic issue, and this is how the whole organization operates, to secure universal access to health services. This is what I wanted to say, and I will conclude with the part that EOPYY is open to cooperations, because I will see the next panel that regards cooperation. We must have an extrovert character, and we must cooperate for the best possible result, both for health economics, but mainly and primarily for patients themselves. Thank you.
Thank you very much, Mr. Kikilias, for the very interesting presentation. You will stay with us in order to have a discussion about the very interesting points pertaining to the catastrophic expenses that Mr. Kyriopoulos will also talk about right now. The point is that cancer and diabetes that have been neglected in the midst of COVID-19 have now taken once again a priority. Very important, the study that you mentioned. Ilias from London. We are now going downtown to the London School of Economics and Political Sciences. Ilias, you have the floor. Good afternoon. I would like to thank you for inviting me to this very interesting session. Many interesting things have already been mentioned. That is why I'm going to be very brief, since we are also lagging behind schedule. Could you please upload the slides, or should I share my screen? Better share, Ilias. It doesn't matter. It doesn't matter. I can go on without the slides. Yes, Ilias, okay. Okay, you can start. As you already said, there are specific trends when it comes to the financing of insurance systems around the world. The basic trend pertains to the growth rate of the insurance expenditure, which is always higher than the increase of GDP, than the growth of GDP. This, of course, raises some question with regard to the sustainability of the funding of the insurance schemes globally. At the same time, well, the WHO and the World Bank have set specific objectives with regard to what we want to achieve through the funding of the insurance systems. One of these objectives is the financial protection vis-à-vis the insurance expenditure, as you have already said. Right now, in Greece, approximately 36% of the expenditure is private, and only 4%, approximately, based on the latest data by OECD, by private insurance. This is not a Greek particularity, however. If one takes a look at the global data, they will see that the social insurance is higher than the private insurance only in 13 countries. In other words, we're talking about a global trend in countries where there is a high uptake of insurance, where many people opt for private insurance, like, for example, France. Less than 10% of the expenditure has to do with private insurance. I'm saying that because it proves that it's not only a Greek characteristic. It's something that we observe in many other countries. And there are also other examples, like, for example, Southern Africa, Brazil, Canada, where private insurance is far more developed. Mr. Yfantopoulos mentioned some studies conducted by his own team. We have also conducted some studies in order to measure how difficult it is for households because of the high expenditure, the high out-of-pocket expenditures. These studies have included not only the general population, but several subgroups of the population. One of the studies mentioned by the previous speaker showed the overall picture of the catastrophic expenses during the crisis. We, in the context of a follow-up study that was published 2 months ago, examined what happened in the population over the 50 years of age, which is the group of high-cost patients. Based on data, it becomes evident that a very small share of the population creates costs for the health sector. In the United States, for example, the top 1% of the population creates 20% of the cost. So the health expenditure, we know where it comes from. It comes from specific groups of the population with many morbidities. So it is important to focus on these groups. We also found out that during the crisis, the expenditure on drugs was a driving force behind the overall expenditure. So these two studies show the importance of financial protection of households. Some other very interesting data. I don't know whether you can move on with the slides. Could you proceed to the next one? Next one. Okay, this one. No, the previous one. So this is very interesting. These show the unmet need. As Mr. Kikilias said earlier, the universal coverage is defined on the basis of three basic factors, one of which is the financial protection, the second is the quality of the care, and the third is the demand for health services and whether this is met. Here we can see that there has been a huge increase in Greece during the crisis, but also after the crisis. Greece is the champion with regard to this. That is, unmet needs. If we move on to the next slide. Next one. We will see that Greece is not only a champion with regard to unmet needs, but also with regard to inequalities of unmet needs, which means that the very rich groups of the population do not have a high share of unmet needs, whereas the biggest group, the more groups of the population have increased unmet needs. In other words, we can see that there is an inequality of the distribution of unmet needs. If we proceed to the next slide, we will see some very interesting findings coming from an OECD study that show that Greece is lagging behind. As you can see on the graph, we show the percentage of health expenditure coming from taxation or social insurance. We can see that it is very low when it comes to hospital and out of hospital. It is zero, basically, when it comes to medical care and very low when it comes to pharmaceutical care. If we compare Greece to the Western European countries, we see that Greece is lagging far behind. And I will conclude with these two last slides. The first one has to do with the reform of the social insurance system and of the taxation. This is the well-known Bismarck versus Beveridge. According to the literature of the last 15 years, this dilemma is a little bit obsolete. Another title that could be given to this dilemma could be a battle between dinosaurs. Basically, the truth is there are no dilemmas like this anymore because we are now in the logic of prepayment to all insurance agents. And there is a variety of studies showing that there is not superiority of the one system over the other. It is very difficult to say that one system is better than the other. It's very difficult to categorize the insurance systems. If you take a look at the OECD data, you will realize that. And if we could move on to the next slide. With regard to private insurance, and maybe we could talk about this topic a little bit later, I believe that whether we should have a discussion about private health insurance, we should answer two questions first. Based on the international experience, it is very difficult to answer these two questions. The first question is, to what extent the private health insurance truly reduces the out-of-pocket expenses and to what extent it improves the financial protection. This is a question that cannot be easily answered, in my view. In countries like the Netherlands, for example, it has been found that indeed it reduces the expenditure, but in other countries like Italy, this is not the case. The second question that needs to be answered is, does it really improve access? And the answer to that question is that indeed it does in the private clinics. Another question is whether it truly improves the efficiency of the organization distribution of health and care services. And last question has to do with what extent these influence the financial pressure that the insurance systems in the wider context of fiscal policy. I had some more things to say. Unfortunately, we don't have the time. So thank you very much for giving me the floor. Thank you, Ilias. Thank you, Mr. Kyriopoulos, for your excellent presentation.
It is interesting, Ilias, if you can comment on the last slide, whether there is full substitution between out-of-the-pocket expenditure and public expenditure and the non-correlation with Social Security. But hold your horses. We will be discussing that at the end. Let us go right away. Dear Mr. Veliotes, you have the floor. You, gentlemen, please remain on call. Mr. Veliotes, you have the floor. Thank you. Let me also thank the organizers for this honorary invitation. I believe that the previous speakers have shared a lot of data. The basic, however, is that in Greece, the average Greek, the main conclusion is that it pays double. There's an overlapping of payments, or paying thrice for the same services, same commodity. This, in substance, is definitely non-effective because we don't share this burden. This burden is not shared, and equally important is the fact that, generally speaking, and this is valid both for the public-private sector as well, we have a system which is focused on the hospital. It is all fragmented, and from the viewpoint of digital development, it's not to the extent and degree that it should be. This model per se is not effective. I believe that through the COVID pandemic, this brought forward these basic fundamental deficiencies and shows that the model will be shaped towards another direction, placing less emphasis on the hospital, more on the out-hospital care, because cumulatively more than 60% of the expenditure is absorbed by chronic diseases, where chronic diseases do not need the hospital. They are dealt with at home with primary care and prevention. The same applies for cancer. When we see a great increase in cancer cases, and as it was said in the previous panel, how diagnosis and identification is dealt with, this needs more specialization and other kind of infrastructure for the future. Therefore, quite quickly, a new services paradigm is shaped, and this demands an adjustment from the viewpoint of insurance as well. And there lies the big opportunity for private insurance. Furthermore, what is very intensely seen, not only in Greece, but throughout in Europe, is the need for mental health. I believe in the era of telemedicine, this has a geometric, exponential increase, and it will continue being so. So what is the future paradigm? The future paradigm is synergies. New and closer synergies are demanded, not with a traditional form. We need both insurance companies and insurer plus services and other non-traditional institutions, such as the pharma industry. A new approach is needed. Let's say, as far as cancer is concerned, where costs and destructive costs are huge, there is a need to participation of all stakeholders on multiple layers. In Greece, you saw from the data presented by Mr. Kyriopoulos, private insurance is low, but is dramatically increasing, and there will be excellent prospects in the future. But in order for it to be further developed and therefore bring about a balance and share the burden of private and public sector, we need a new framework, a framework that would clearly stating the roles and responsibilities, who covers what. And time is needed. In other countries have done so. Perhaps the best example is the Netherlands, where they studied and planned and implemented. It took them 15 years. That's why it's considered one of the best European health system. And there we can find a true partnership, a true PPP. In Greece, there are certain points where there is participation and partnership. And there I give the example of the NRGs, where there is cooperation both of the private and public system. This is a very strong point of contact and cooperation. That's why as a market, insurance market, we support it greatly, because it is one of the basic points that must be radically restructured. In order to build this future, however, we must sit all around the table. We need coordination, a common vision, and trust in capital letters. This is the basic point. And we may learn from other countries. We don't have to reinvent the wheel. Excellent example is the Netherlands. Australia has an amazing paradigm to offer. And to a certain extent, Spain as well. I believe that there are many opportunities, and the digital era will definitely pave the way for new paradigms, new cooperations. We participate in a European platform where 22 countries are present, and the digital projects currently running during the pandemic are unbelievable, the pace and quality. And I don't speak of Southern European countries, but developed countries as well, such as Sweden, the Netherlands. And this, for us, is also the big opportunity. As is the case, I believe that the big gap in Greece is primary care, where both for the private and public sector, along with the digital activity and development, we have the ideal opportunity to build a brand and bright new future, where private insurance will also have a very substantial role to play. Thank you. We thank you, Mr. Veliotes. Thank you for your intervention and for observing the time. Ladies and gentlemen, I would love to give the floor to Mr. Kikilias, Kyriopoulos, and Veliotes for a second round, but then I got a message. It reads as follows. My dearest Yfantopoulos, we have exceeded the time. Please make haste. You should be finished. But before completing, I know that I transgress the secrets. Madam Antonaki, complementarity and recognizing the private. Mr. Kikilias, coverage of uninsured, new regulation for cancer, diabetes, new treatments, cooperations. Mr. Kyriopoulos, unmet needs imbalances. Mr. Veliotes, chronic diseases, Dutch paradigm, compulsory private health insurance, necessity for mental health, future paradigm, cooperation, coordination, and all that brings us together for this new platform. We have to express our gratitude here to all the speakers.